On physical exam, important physical exam of both lower extremities is necessary to detect signs of ischemia. You can't just inspect one limb. And in the inspection of both lower extremities, the arterial obstructions are usually one joint above the level of demarcation between the normal and ischemic tissues. So when you perform a neurological exam, you have to obviously examine both extremities, and you want to test the sensation as well as the muscle strength. And the quality and character of the peripheral pulses in both lower extremities have to be examined and compared with each other. The vascular exam should include palpation of all the pedal pulses, including the femoral, the popliteal, the dorsalis pedis, the posterior tibial, and even the upper extremities, because they can have critical ischemia in your upper extremities, which is often overlooked. And a handheld Doppler should also be used in the presence of distal pulses to evaluate any arterial or venous signals. So just Doppler signals, if they're present, the ankle brachial index should be obtained, and a general rule is that in any absence of any Doppler signals, arterial and venous insufficiency indicates severe ischemia. So quick review, we want a triphasic Doppler signal, so that's like shh, and then a biphasic says that the patient has moderate disease, mild to moderate disease, which is like shh. Wow, I literally just sound like choo-choo train. This is for education. And monophasic pulses, like a shh signal, is very, very bad, or an absent signal is even worse. So that is, I would say, a medical urgency. Also, regarding the lower extremities, although arterial blood flow studies can vary depending upon the location of the thrombus or embolus, a value of less than 0.4 does indicate severe limb ischemia. As I mentioned before, I'm going to talk about acute limb ischemia as well, because we will see patients with this, and what is important to remember are the 6 Ps. So pain that's associated with acute arterial occlusion is usually located distally in the extremity. It does increase in severity and progression, and it does increase with the duration of the ischemia. And the pain can later decrease in severity due to the progressive ischemic sensory loss. So that again links us back to our neuropathic diabetic patients. Skin perfusion, the skin of both the normal and affected extremity should be examined for temperature, color, capillary refill time, and the skin of the ischemic extremity is cool. So you have your second P up there, poikilothermia, and pallor with delayed filling, and sometimes it does present with blistering. Furthermore, signs of chronic limb ischemia, such as atrophy of the skin and hair loss and thickened nails, can present in our patient populations. Pulses. So acute limb ischemia typically manifests with severely reduced pulses. Normal pulses in the contralateral extremity usually suggest that an embolus is the etiology of the acute ischemic event, and that the chronic arterial obstructive disease is unlikely. But on the contrary, reduced pulses in the asymptomatic contralateral extremity indicates the presence of underlying chronic disease, and this does allude to acute thrombus of an already diseased vessel as a likely cause of the acute ischemia. And on our neurologic examination, deficits such as numbness or paresthesias are all signs of early nerve dysfunction secondary to the ischemia. And major loss of sensory motor function, such as paralysis, indicates advanced ischemia. And in the lower extremity, our anterior compartment, which is outlined in blue here, is the first to be sensitive and likely to go to our ischemia. And this includes our anterior tibial artery. So sensory deficits over the dorsum of the foot are often the earliest neurological signs of acute vascular insufficiency. Super quick, just to touch on our anatomy so we're all up to date. Right under our inguinal ligament, we have our deep femoral artery, which branches into our femoral, then goes into our popliteal, our anterior tibial, posterior tibial, all branch off of that, as well as our fibular, and then we all have our pedal areas. And quickly, just to touch with that, our younger populations need to be addressed more critically because ischemia presents itself differently in them. And it is extremely important to check the popliteal and femoral pulses of this population because they may have claudication and chronic limb ischemia, even though pedal pulses are present, because blockages can present themselves differently in the younger population. Also, something to note, I think this is really important for everyone just to memorize. It's a quick diagram. These are just angiosomes, the distribution of the anterior tibial and posterior tibial and peroneal arteries, and the perfusion of the pattern into the foot and lower leg. So a lot of times I'm asked by either cardiovascular interventional surgeons or vascular surgeons, hey, I opened up the anterior tibial, can you just do a TMA or can you do a toe amputation? And I asked them, is the posterior tibial occluded? And they're like, yeah, but the anterior tibial is completely open, so you can go ahead with your amputation. No, I can't, because that patient will result in gangrene. And a lot of even physicians don't understand the importance of the posterior tibial artery. So I will argue as a physician in practice that for me, the posterior tibial artery is the most important one, and it really tells me how successful my amputation will be. So to all the vascular surgeons and cardiovascular interventional surgeons out there, if you can get me a posterior tibial artery, it will be greatly appreciated. The goal is to preserve limb function. So revascularization is a fundamental strategy to limb preservation, but in some patients it does not improve limb function and mobility. So cognitive impairments, a patient that's already non-ambulatory before any critical limb ischemia, severe comorbidities do predict a poor prognosis even if vascular procedures are performed and they are successful. When revascularization is considered, arterial imaging identifies the targets and mode of revascularization. So we can use a duplex ultrasound and other non-invasive angiography with either a CTA or an MRA to demonstrate arterial obstruction. And duplex ultrasound does not require contrast, but it does require specific training that many hospital technologists do not have. So you really have to talk with your staff downstairs to see if we even have these options available at our hospitals. And in infrainguinal disease, vein mapping is required to determine the feasibility of surgical bypass with the autogenous vein. So some testing. The CTA does require iodinated contrast, and this can cause toxicity of contrast and nephropathy in many of our patients who do or do not have decreased renal function entering this exam. So heavily calcified arteries can create artifact that limit the CTA, which are more prevalent in the distal vessel disease. Non-contrast time of flight MRA is prone to artifact of the plaque that we have and the sclerosis, and concerns of nephrogenic systemic fibrosis from the contrast that is used does limit MRA use in advanced kidney disease. CTA and MRA can help localize disease targets and help formulate a plan to treat the mode and what approach to use for revascularization. CTA and MRA are sometimes inadequate to assess the smaller tibial vessels and distal arteries. Therefore, invasive angiography is often needed to clarify the need for revascularization and has to be considered before any major amputation is performed, so anything at or above the ankle level. Invasive angiography uses iodinated contrast and provides a high spatial resolution, and as little as 30 milliliters of this contrast can actually be used for both lower extremities in conventional and digital subtraction angiography. So what do we do? What is our treatment modality? How do we help these patients? So initial treatments include pain control, pressure relief of ulcers, sheepskin boots to increase superficial collateral supply, and as I touched on before, we can tilt the bed to decrease limb dependency and increase our pedal perfusion. Pain relief may reverse sympathetic mediated vasoconstriction, and many of my patients do require morphine. Although some of these measures do not significantly improve perfusion, they may reduce the pain that the patients experience, which buys us time, so we can properly assess and plan of how to treat our patients.